Hello and welcome to the first of a series of online e-tutorials that are going to be looking at an introduction to systemic pathology. In this first tutorial we're going to be having a look at upper GI pathology, and while we're not going to be covering excessive amounts of detail in this tutorial, hopefully it will give you a good grounding in basic upper GI pathology. So as always, you can tweet us at Biteside Pathology, and you can also comment below, and of course you can click the subscribe button. So what are we going to cover today? Well, first of all, we're going to be talking about esophageal cancer. We're going to identify some of the main classifications of esophageal cancer. We'll look at the common risk factors for esophageal carcinoma that you'll encounter in clinical practice, and then we'll describe some of the pathological changes that you see in a condition that's known as Barrett's esophagus, and we'll talk about why that's significant. We'll then move on to looking at the pathogenesis of peptic ulcer disease, and we'll identify again some of the risk factors that are related to that, and finally we'll cover some pathology related to pancreatic carcinoma. So to start with, esophageal cancer. Esophageal cancer is responsible for a significant amount of morbidity and mortality. So this data is gathered from Cancer Research UK. It's a few years old now, but it really does emphasize how significant problem esophageal cancer can be. So in 2014, it was the 6th most common cause of cancer death. It's much more common in men than it is in women, but what you can see is that survival at 10 years is actually quite poor. It's only 12% of patients alive at 10 years. And what is also striking about this data is that around just under 90% of the cases that we see of esophageal cancer could have been prevented. So there's things that we can do in order to intervene and hopefully prevent people from getting esophageal cancer. So how do we classify esophageal cancer? Well, you remember that the esophagus is lined by stratified squamous epithelium, and one of the more common forms of esophageal cancer is squamous cell carcinoma, but the most common form in the UK is actually adenocarcinoma, which is arising from glandular tissue, and that's related to the condition called Barrett's esophagus that we'll come back and chat about in a second. There are also some other forms of esophageal cancer, one that's called undifferentiated esophageal cancer, so we're not quite sure the type of cells from which that's arisen from. And also we have melanomas that can exist in the esophagus, and also lymphomas that can exist in the esophagus as well. But they're much more rare. We're not going to really cover those. Squamous cell carcinoma is more common in Eastern countries, and it tends to be more confined to the upper parts of the esophagus, the upper and middle part. You'll often see in textbooks the esophagus is split up into thirds, so you have an upper third, middle third and lower third, and it's the upper and middle thirds where you'll get the squamous cell carcinomas. Whereas the lower part of the esophagus, particularly around the gastroesophageal junction where the terminal end of the esophagus meets the cardia of the stomach, that's where you find your adenocarcinomas. So what are the risk factors for esophageal cancer? Well, obesity is becoming an increasing problem and is a significant risk factor for esophageal cancer, as is smoking, particularly squamous cell carcinomas. Alcohol is a major risk factor. It leads to reflux disease, it leads to gastritis and esophagitis. That causes chronic inflammation, and therefore any chronic inflammatory process that's irritating things will cause cellular change and predispose to cancers. There is a gender effect. It's much more common in men than it is in women, and the incidence of esophageal cancer does increase with age. But one significant risk factor that you'll come across is something called Barrett's esophagus, and just want to spend a bit of time talking about that. So what is Barrett's esophagus? Well, it's a cellular change. In fact, it's a metaplastic transformation. So that's changing from one terminally differentiated cell type into another terminally differentiated cell type. In this case, it's changing that squamous cell epithelium of the esophagus into a columnar epithelium with goblet cells. And if you know histology, you'll know that's a familiar description of intestinal epithelium. So it's also known as intestinal metaplasia. So Barrett's esophagus is a metaplastic transformation of squamous epithelium into columnar epithelium with goblet cells. It's a response to chronic inflammation, so patients that have chronic reflux disease are predisposed to developing Barrett's esophagus. And Barrett's esophagus will increase your risk of adenocarcinoma, so the carcinoma arising from glandular tissue in the lower portion of the esophagus. And of course that's because you've got this intestinal change, you've got changing in the genetic material, you've got mutations in cells, and that can very easily go wrong, lead to dysplasia, and then you've got the setup for a cancer. So just looking at that visually, the squamous epithelium of the esophagus is shown on the left, and then on the far right you can see that columnar epithelium with the blobs of goblet cells that are in between, and you can see some of the glandular tissue there as well. Now the picture in the middle is an endoscopic picture, and that red, very raw looking area is where the epithelium is changed into that intestinal epithelium. That's around the gastroesophageal junction, so that's a very common site to find it in the lower portion of the esophagus. Now patients that have Barrett's esophagus, when it's identified, usually on endoscopic study and then taking a histological sample, when we identify it we tend to monitor patients because we know that there's an increased risk of developing cancer. And so those patients will be monitored with surveillance endoscopies. So what are the clinical features of esophageal cancer? Well, unfortunately, it does tend to present quite late, and patients can present with quite non-specific symptoms, but symptoms that should raise a red flag for you: difficulty swallowing, or in older terms dysphagia, and weight loss are the two most common things that should raise your awareness to the fact that this could be esophageal cancer. Other symptoms that patients might present with include vomiting blood, hematemesis, and any patient that's had resistant dyspepsia, so heartburn that's just not responding to anything at all and is ongoing, and particularly in those patients that are aged over 55. Again, because of that link that we've just talked about with increasing age. And the NICE guidelines in the UK mimic this, or they are based on this, and they tell clinicians to refer people under a 2-week wait to assess for esophageal cancer by doing an endoscopic investigation for patients that have got difficulty swallowing or are aged over 55 and have weight loss and any of those symptoms of upper abdominal pain, reflux, or dyspepsia. So once somebody has been found to have esophageal cancer, we then need to stage it. Now you remember that there's grading and staging in cancers. Grading is to do with the cellular changes and how typical the cells are of a normal esophagus. So that's a separate topic that I'm not really going to cover. Whereas staging is to do with the spread of the disease. And you do that by looking at it down the microscope, but you also do that by having a look at radiological investigations and other investigations. And a particularly popular thing to do now is endoscopic ultrasound. So you can put an endoscope with an ultrasound probe on it and look at the depth of the tumour invasion into the wall. And what you can see here is just the staging system, which is TNM, so that's tumour nodes metastases, and you can see the various T stages presented in these images. So T1 being confined into that sort of upper edge of the epithelium, whereas T2 is extending down into the muscular layer, T3 is going through and out to the serosal layer, whereas the T4 stage is actually invading into other structures. And of course, the deeper it gets, the worse the prognosis. And that's really significant. The other thing that's significant for prognosis is the number of lymph nodes that are involved, and of course metastases to other organs. So treatments, various things: chemotherapy, radiotherapy. I'm not going to go into the details of this because that's more for clinical oncology. Things to mention: some people do have a surgically resectable esophageal cancer. They tend to be younger, fitter patients. And we do a procedure that's known as an Ivor-Lewis resection. So you take out the length of the esophagus essentially and join up the cardia of the stomach to the pharynx. So it's a very major operation. However, most patients are not able to do that, and they present quite late. The tumour's already grown quite a bit and they suffer from really very bad symptoms. And so it's about symptom management, it's about giving palliative chemo and radiotherapy to try and shrink the tumour and relieve symptoms. Many patients will have a stent put into the esophagus just to widen it up to allow them to swallow. And that's really esophageal cancer. That's the ABC of esophageal cancer. So moving on to peptic ulcers. An ulceration is simply a break in an epithelium. It's a break in the gastric mucosa. When we're talking about peptic ulceration, we're talking about a break in the gastric mucosa. And this microscopic image here, this histological image, is showing you where you have normal epithelium and a break in that in the middle, and that region there is the ulcer. And you can see just sort of the darker areas are showing you that there's lots of inflammatory cells in there. So there's lots of cells that are trying to fight off and destroy whatever's causing that. Now, this bug on the right is the bug that's responsible for the majority of these ulcers. It's called Helicobacter pylori. It's a gram-negative spirochete, and it's particularly clever. It can evade many of the defensive mechanisms of the stomach, so it can survive in that acidic environment. It can break through the mucus by releasing an enzyme called urease, and it produces ammonia, and that ammonia will then irritate the gastric lining. So it can break down the mucus, which isn't great because you're exposing then your epithelium to the acids of the stomach, but also it produces this enzyme which releases ammonia, and then as a consequence of that you then get more damage. So Helicobacter pylori is responsible for the majority of this, and the people that discovered that won a Nobel Prize. And majority of people that do have Helicobacter pylori, about 85% of them will have no symptoms whatsoever, but some people will develop peptic ulcers. Now, peptic ulceration is more common in the duodenum than the stomach, and when you do sort of clinical surgery modules, talk about the symptoms that you get with each and how you can differentiate between the two. But the majority of peptic ulcers are actually found in the duodenum, and that's a really important point. So, more importantly, what are the other causes of peptic ulceration? And how do they cause peptic ulceration? Because understanding why will hopefully shed some light on why these things can be altered as well. So the first thing are non-steroidal anti-inflammatory drugs. Things like ibuprofen, diclofenac, all of those COX inhibitors. They are irritant themselves to the lining of the stomach. They decrease mucus production because they inhibit prostaglandin synthesis, and this results in a reduced mucus production, and they also break down the mucosal barrier. So NSAIDs have to be given either in conjunction with something that will reduce acid production, such as a PPI, or they're taken with food in order to protect the gastric lining. Similarly, corticosteroids will also irritate the lining, and they will impair healing because they have an immunosuppressive effect as well. Alcohol is very irritant, and alcoholic gastritis is an example of that, but also can lead to ulceration. Smoking, again, is an irritant. And then small print stuff here, but things that will increase your acid production. So Zollinger-Ellison syndrome is basically where you have a gastrin-secreting tumour in the pancreas. And what happens as a result of that is you get an increased amount of hydrogen ion or acid production as a result of stimulation from gastrin. So that's something that sometimes comes up in exams in small print stuff. So what do you do about a peptic ulcer when you have one? Well, for a start, just to make the point that preventing them in the first place by modifying all the things that we've just talked about, so making sure that you don't smoke and reduce your alcohol intake, and also that you stop taking as many medications that could potentially cause peptic ulcerations. But when you've got them, what you need to do is eradicate that H. pylori bug, because by and large that will be the responsible organism. So we give a triple therapy regime of an antibiotic, and the last I knew it was sort of amoxicillin, or if you were penicillin allergic, it was a macrolide like clarithromycin, and metronidazole to give some anaerobic cover as well, and then also give that in conjunction with a proton pump inhibitor such as omeprazole that will reduce the effect of the gastric acid as well. So peptic ulceration is really interesting because it can lead on then to a number of complications. So it can lead to perforation because the ulcer can break through the wall that much that it comes out the other side, and you get perforation, and you will get air under the diaphragm, what we call pneumoperitoneum, and you'll see that on an erect chest x-ray. And it can also lead to massive bleeding, And also, people have previously looked at whether they cause malignant change. I think that's still very, very debatable. But of course, you can get chronic ulceration and you can get chronic scarring and granulation tissue. But bleeding and perforation are the two really important things to think about. So finally, in this tutorial, we're going to talk about pancreatic cancer. Now, unfortunately, when you look at the statistics of pancreatic cancer, you can see it has a very poor outcome. Less than 1% of patients that are diagnosed with pancreatic carcinoma are alive at 10 years. And this is because it does present very late. The symptoms are very vague because patients often present very insidiously with pancreatic cancer. And actually, not a huge number of them are preventable. And we still don't understand a lot about pancreatic cancer, but we know that it's a cancer that doesn't have a very good prognosis. But there are lots of things that we can do in order to help people who do have pancreatic cancers. So to talk about the pathology of pancreatic cancers, there's lots of weird and wonderful tumours and things that you can get at the pancreas, but the most common cause of pancreatic carcinoma is ductal adenocarcinoma. So that's a cancer affecting the cells that line the pancreatic duct. Most of these tumours occur in the head of the pancreas. So around 65% of tumours are found in the head of the pancreas. Now, just looking at this diagram here taken from cancer research, you can see that that will have a significant impact on structures that surround that tissue. So you can see very close to the head of the pancreas, you have the duodenum, which is looping round. The second part of the duodenum comes and loops around there. You can also see that the common bile duct joins up with the pancreatic duct at the ampulla of Vater there and opens out and empties into the duodenum. So you can see that this could cause significant problems, and indeed it does. So patients that have jaundice but have no pain and have a palpable mass are patients in which you should be strongly suspicious of pancreatic cancer. And people that have a distorted liver function test, where there's a raised alkaline phosphatase that potentially suggests that there's some obstruction to bile flow, then we need to consider whether or not patients do have indeed a pancreatic cancer. It's a very insidious presentation, and it presents very late for that reason. There can be vague symptoms such as pain in the back, pain in the abdomen, just feeling very tired, losing weight. They're more common than patients that will just present with painless jaundice. But it's really important to consider that patients that present with pancreatic carcinoma, around 85% of those patients will already have involvement of surrounding tissue. It will already have spread beyond the pancreas. It will already have spread beyond the head of the pancreas. So what are the risk factors for pancreatic carcinoma? Well, of course, alcohol intake and smoking is also a significant risk factor, but really significant again is obesity, which is an increasing problem, and it is linked to pancreatic carcinoma. Chronic pancreatitis is again linked into alcoholism, but people can also have chronic autoimmune pancreatitis. And again, it's this inflammatory process, it's this constant damage to cells that causes them to repair, and during that repair process there will be a problem and mutations arise, and then they're repeated, and all of a sudden we've got dysplasia and we've got that carcinoma sequence kicking off. Diabetes, again, there's damage to the pancreas, and anybody that's had a previous malignancy, you need to think about it as well. Now, pancreatic carcinoma is really important to try and recognise clinically. As I've said already, it's really difficult sometimes to find a pancreatic cancer, and that's why it presents late, and that's why the figures in terms of mortality look like they do. So we've had a very quick tour of some upper GI pathology. I specifically didn't cover the stomach in this, but hopefully we'll cover that in another tutorial, and that's because it's not as common as some of the pathologies I've presented here. But we have gone through the main classifications of esophageal cancer. We've looked at the common risk factors for esophageal cancer. We've looked at the pathological changes in Barrett's esophagus and described why they're important. And then we've described the pathogenesis of peptic ulcer disease and why you get that. We looked at the common risk factors for peptic ulcer disease. And finally, we finished off looking, albeit briefly, at the pathology of pancreatic carcinoma. So I hope you enjoyed this tutorial, hope it was useful, and hopefully I'll see you for the next one.